Great. Okay. I'm going to ask that everyone just a little reminder to mute if you can. And hello, I am going to start by sharing this presentation. Let me know if you are having trouble seeing it. Um, Everyone good? Can see it just fine? Great. Okay, so welcome. I am so excited everybody's here. I'm seeing mostly psychologists, therapists. I saw, I think, a nutritionist in here as well. So I asked that to see if I can tailor this presentation to you and what you need, because my hope is that I'm really speaking to your needs. I'm really passionate about this, and so let's sort of jump in. Today, we're talking about assessing and understanding birth trauma, transform your practice with a trauma-informed approach. And I'll be introducing you to what's called the Well Mother Checklist. And it's an assessment tool, it's a non-diagnostic tool that you can use with your clients to help you get an understanding of whether or not they've experienced a birth trauma, to get a little bit of an understanding of the past, the present, and the future. We'll go through it. That'll make a little more sense later on, and sort of how that's being affected. Let me start by, just introducing myself. So again, I'm Dr. Rebecca Branda. I'm a licensed clinical psychologist, and I'm the owner of Birth Feelings. I'm licensed in California and Illinois, and I'm an adjunct professor as well at Northwestern University. And my expertise is in trauma. I do EMDR, psychodynamic, CBT, and women's mental health. I've trained at places like Bellevue Hospital Center in New York, the 9/11 World Trade Center Clinic, and at Northwestern. And I'm a mom of two boys, and I'm a VBAC mom and a birth trauma survivor. And so I am really hopeful that both my personal experience and my educational experience can be something we can all learn from and sort of use and integrate in our practices. So at Birth Feelings, we focus on birth therapy. Birth therapy recognizes that birth is not just a physical event, but it's a deeply emotional and transformative experience. We focus on emotional and psychological complexities of birth, and the goal is to address how birth impacts the past, so a mother's past, her present, and her future. I do want to give a small disclaimer that I am using the word mother and mama, and that is not to leave anybody out. It is not to speak to gender. It's for ease of use. And so I'm hoping that we can all feel comfortable with that. Should there be any questions or concerns, please reach out to me. I'm happy to talk with you around that decision, or whether, that made you feel uncomfortable in any way. So let's jump in. My hope is by the end of this, you can define and recognize birth trauma. Again, I'm going to introduce that Well Mother checklist, and I want you to be able to apply trauma-informed care for mothers and really help you get some clinical applications for your practice. I'll try to keep this presentation for therapists and psychologists, since it seems like that's most of you. But if you have any questions, please jump in. My goal really here is to advocate for birth and advocate for mothers. And so I want this to be something that supports you and your practice. Okay. Okay, so let's start with defining trauma and birth trauma. So trauma results from an exposure to an incident or series of events that are emotionally disturbing or life-threatening, with lasting adverse effects on mental, emotional, and physical well-being. So really, trauma overwhelms the body's ability to cope, and it has lasting effects, which we see come out in anxiety, in depression, in challenges in relationships. And my goal through talking about birth trauma is to understand some of those nuances and how you may be seeing trauma and not even realizing it. Birth trauma is the physical and or emotional distress experienced by a mother during and after childbirth. And this is a statistic that I was not thrilled to know about, but hopefully it will sort of change your thinking about the way you talk to the mothers you work with. 1 in 3 mothers report experiencing birth traumas. So that means if you work with 3 clients, you may have one who have given birth at any time in their life. One of them may report that their birth experience was traumatic. And birth trauma can result from a variety of factors: complicated delivery, medical interventions, unexpected outcomes. And oftentimes, birth trauma brings up past traumas. It can also be a standalone experience, but as most of us therapists and psychologists know, it rarely is just a standalone experience. And so it's really important, and that's what I'm hoping the Well Mother Checklist will help everybody do, to understand how those past experiences are either being brought up or helping us or hurting us in understanding what's happening in the present. And birth trauma can change a mother's view of herself, her body, her relationships with her partner, her children, her family. So it really is life changing. So this might be a little basic, but I feel like I have to do it. I just want to talk through the neurobiological underpinnings of trauma. And I'm going to use the hand model. If people are familiar with Dan Siegel's work, he does a lot of explanation and has some great books and research on this. But basically, I feel like it can be helpful to sort of understand the structure and how the brain is working when it's been traumatized, so that you can get a sense of either explaining it to your clients or understanding it yourself. So again, I'm going to use the hand to sort of like be my brain. And basically what we're seeing here is we're looking at the vagus nerve, which sends the signals from the brain to the body. And then we're looking at the brainstem here, and that's sort of controlling our breathing, our heartbeat, things we're not really thinking about. And then inside here is our limbic system, where we're having the emotional processing. So amygdala is in there, hippocampus is in there. Amygdala, we're thinking, emotional processing. Hippocampus, we're thinking memory and learning. And we're seeing in the limbic system the four F's: the fight, flight, freeze, fawn responses are all regulated in here. Then we're having the cortex, so this sort of upper part of our brain, which is the thinking brain. And in here, we're seeing the prefrontal cortex. And what happens in a traumatized brain is basically this prefrontal cortex becomes inactivated or dysfunctional and stops working and being connected to this amygdala. And so these responses are out of control or just not in line with what they're currently experiencing. And so Dan Siegel talks a lot about like toddlers sort of flipping their lid, and this idea that the prefrontal cortex is no longer modulating the amygdala, those fight, flight, freeze, fawn responses. So yeah, it can be important to think about the brain is not working in the way we want it to be working, and how do we create more integration in the brain. If there's any questions on that, please let me know. And if that's something you already know, then I appreciate you sitting by. In terms of trauma responses, that's the living legacy of trauma. So we can talk about how trauma affects us in the moment, but what happens is trauma then leaves that lifelong scar. And so I want to talk through the four F's. Many of us are probably familiar with one and two and are becoming more familiar with three and four. So in the fight response, we are seeing this surge of energy wanting to fight. That means in practice, we're seeing rage, we're seeing anger, sometimes we're seeing bullying, intimidation. This idea that if I can create control, so if I think I can control others, I can create safety. In flight, we are seeing panic, worry, perfectionism, this idea that someone is sort of always doing, always trying to get out of there, almost as if their starter button is sort of stuck on all the time. In freeze, we're seeing dissociation, which I will talk about in a little bit, difficulty making decisions, numb, stuck, as if the starter button isn't off. They just can't seem to get going. And then the last one is fawn. This fawn is basically appeasing the perceived threat. So a lot of times you'll see identity confusion, difficulty setting boundaries, codependency, you'll see people pleasers. These are individuals that believe that they can stay safe if they abandon themselves and fully give themselves over to the thing they think has harmed them. Um, and so, again, what you might be seeing in your practice is rage and thinking, this rage does not make sense to me. What's going on here? And that might sort of make you think about, is there a trauma in their history I haven't addressed? Have I asked them about their birth experience? I've worked with someone whose kids are in their uh, late teens and 20s. And I just said to her, how was your birth experience with your kids? And it turned out she had a pretty traumatic birth with her first and a more healing birth with her second. But basically, the experience was traumatic and she is still wearing those scars. So, what's important about trauma responses is that they are adaptive. I know that doesn't quite make sense. Rage is adaptive, bullying is adaptive. What I mean by that is it is adaptive to the person. It is something that they have done to keep themselves safe. And so, what we want to be thinking about is I don't want to remove these responses. I do not want them to have no ground to stand on. I want to replace them. And so, being mindful of how, in that early processing and healing times, the ground may feel shaky, but that's because you're trying to replace the ground that they're standing on rather than sort of fully taking it away. And also, trauma responses are the root of trauma symptoms. Okay, that feels sort of obvious, right? But what I'm thinking and talking about is a little different than what you might think about in terms of the root of trauma symptoms. So, PTSD, whether it's clinical or subclinical diagnosis, you're seeing numbing, few or no memories, nightmares, flashbacks, hypervigilance, so sort of being on edge, mistrust, dissociation or feeling out of body, loss of identity, things like that. You also can be seeing anxious symptoms. So you could be seeing anxiety, worry, panic attacks, irritability. Um, and again, I'm talking about this because what often happens is someone comes into the room and says, I'm an anxious person. And we say, okay, let's treat your anxiety. We don't always think, well, is this anxiety actually from your trauma? And do we actually not see you and not fully treat you if we're just treating your anxiety? Instead, we need to look holistically at you and treat your trauma and treat the symptoms that are occurring from your trauma, such as anxiety. Other symptoms we're seeing are depressive symptoms. So, loss of interest, decreased concentration. We're sometimes seeing insomnia, emotional overwhelm, hopelessness, shame, worthlessness, and self destructive behaviors. And the last is physical. So sometimes we're seeing chronic pain, headaches, unexplained pain or
Mm.
illnesses. And
You want to add one?
these are things that we sort of want to think more about. So if someone's coming in saying, I go to my neurologist for my chronic headaches, but I don't know what to do, they're not going away. Is this also psychologically mediated? And so now that we sort of understand what we're looking for when we're seeing someone come into the work and thinking about birth trauma, I want to create a distinction between what we're seeing in a non traumatized mother and a traumatized mother. So, in a non traumatized mother, we're generally seeing a pretty linear birth story, someone who can say, went into labor, this happened, that happened. Everything sort of makes sense. The way the memories were stored are linear. Whereas in a traumatized mother, we're seeing non-linear or non-existent birth stories. So the memories are stored in a traumatic way. And so the story might sound like, well, baby was in the NICU. Oh, wait, no, I had preterm labor. No, it wasn't considered preterm. And the story just sort of doesn't make sense. You also might see a mom who's just like, nope, I am not telling you that story. And, respect that. Okay, mom does not want to tell that story. A non traumatized mom we're seeing can meet babies' needs. Um, and uh, basically, a traumatized mother is someone who's unable to meet babies' needs. A non traumatized mother has a pretty stable mood and it's important to think about stable doesn't mean good. It doesn't mean they're just doing great. What we mean by stable mood is they're sort of within that window of tolerance. Their mood is low sometimes, it's high sometimes, but it's not extremely low or extremely high. Whereas with a traumatized mother, we're seeing a pretty unstable mood. Maybe we're seeing extreme tearfulness or extreme joy, but it's sort of outside of that window of tolerance. For non-traumatized mothers, we're seeing a shift in identity. That makes sense. Went from being a woman who was pregnant or a person who was pregnant to being a person who now cares for a baby outside of the womb. And so there is this shift of identity. For traumatized mothers, you're hearing a loss of identity. I don't know who I am. I don't know if I can get back to my work. I don't know if I can take care of baby, things like that. A non-traumatized mother you're seeing is connected to herself or their self, connected to friends, family, and a traumatized mother is disconnected. In terms of, again, a non traumatized mother's mood, we sort of understand that they're exhausted. Whereas with a traumatized mother, we're seeing overwhelming exhaustion. They might say things like, I just don't think I can go on. I don't think I can keep doing this. Instead of, I'm just so tired, all I can think about is a nap. There is sort of a difference in that language of being understandably exhausted versus overwhelmingly exhausted. Again, sort of a non traumatized mother can really read baby's cues. And it's important to note that maybe not immediately when baby is born, but over time, they sort of learn what a hunger cry is versus a tired cry and things like that. Whereas a traumatized mother will really say, I don't know what everybody else is talking about the difference in cries, or I don't really know what they're talking about in terms of how baby is hungry. And so you're sort of hearing like, oh, that's interesting. You must be struggling to connect. Maybe there's a trauma. A non-traumatized mother accepts their body, and a traumatized mother likely hates their body. They might say things like, I feel disfigured or ugly, or I hate the way I look. And a non traumatized mother has understandable frustration. Whereas a traumatized mother, you're seeing agitation, anger, you're seeing rage. And I think the gist of this list, if we sort of want to look at it holistically, is the extremes, is oftentimes what we're seeing in a traumatized mother versus a non traumatized mother. So now I want to sort of have us think and talk about how we can like test for or check for um, trauma, so, birth trauma, sorry. So I want to introduce the Well Mother checklist. And this checklist assesses how deeply rooted and multifaceted birth trauma can be for mothers. It's there as a tool for you, for the 1 in 3 mothers who experience birth trauma, to really get a sense of what is going on with them. How can we support them? How can we understand them? And it does that by evaluating how birth trauma impacts their present well-being, their as well as their future choices. So I'm not sure if usually I try and give out the checklist. I will just pop a link in here and I will have a QR code because I want you guys to have access to the Well Mother checklist as I'm going through it, so that you can get an understanding of how it can support your practice. So I'm going to link it here and keep going. But basically, sorry, okay. So assessing trauma. So the Well Mother checklist goes through the past. It tries to identify the root of the trauma, the impact it has on shaping mom's identity, her journey. It talks about the present, sort of recognizing current symptoms. We're thinking body, relationships, self-perception, and then the future, exploring how your hopes, fears, and expectations evolve as your identity is evolving. So here again is a way to get directly to the Well Mother checklist um, from my website, and hopefully people have that. Otherwise, you can just grab it from the chat. So let's go through it. What does this mean? How can I use it? Why is it here? Basically, this checklist is something that we will talk through because what I want you to be able to do is use it for your practice in the way that feels comfortable. So it's pretty easy to give. I can either send you a PDF of it or you can sort of give them the link to the website. But basically, it's broken down into those three sections: past, present, and future. And there are 15 questions, five in each section. And the responses are never, sometimes, or always, and they're scored in that way. If someone responds with a never, it's a 0, sometimes it's a 1, and always it's a 2. And the interpretation bands you can use are 0 to 10 is minimal impact, meaning experiences of trauma might not really have a significant effect on their current functioning. Moderate impact, that 11 to 20, you're thinking some indications of trauma, maybe further exploration or some support may be beneficial. And if you're a mental health provider, it might mean the support is coming from you. If you're outside of the space, it might mean you're referring out. And then 21 to 30, that significant impact, which means there are clear signs that trauma is affecting various aspects of the individual's life, and intervention is strongly recommended. Um, okay. So my thought for the rest of the time is that I'll sort of talk through trauma-informed integration using a case study for the checklist. And if people have questions around the checklist or questions around the case, we can sort of talk together about those. But what I'm going to be going through in the checklist, we're going to use these four as sort of our basics. So we're going to be talking about trauma-informed integration through body awareness, recognizing physical cues of dysregulation, safe spaces, so creating non-judgmental environments, cognitive restructuring, so addressing those negative self-beliefs, and relational repair, rebuilding that trust in self and in others. So here we're going to talk about Mia. Mia is a late 30s Irish American married female with a history of childhood sexual trauma. She has no reported history of physical or mental health diagnoses, and she's a successful lawyer. She has no reported challenges with conception, one first trimester miscarriage, and then an uncomplicated pregnancy. Her daughter was born via emergency C-section 20 months prior, and she was unable to breastfeed her daughter. She's currently pregnant with her son and interested in a VBAC, a vaginal birth after cesarean. She's coming in to the work to help get ready for the birth of her second child. And when we ask her what has brought her in, she becomes tearful. So, what in Mia's story are we thinking might lead us to think about, is trauma affecting her? Do we need the checklist? I can answer that, but I'm sort of thinking I'll open it up to the chat to see if people are comfortable responding as to what they would what would pique their curiosity around why they give the checklist. Tearfulness? Yes. So emotional lability is an indicator that there might be some feelings around this, some unstable mood, definitely a trauma indicator. What else? Not having the birth she wanted the first time. Exactly. Childhood sexual abuse. Exactly. So we're thinking not being able to breastfeed. Spot on. Yes. And one more that I'm thinking about that maybe people are also thinking about would be her miscarriage. So basically, what everybody in here is getting at is the idea that her history is probably leading to tell us there might be a birth trauma, and we want to figure out if that's the case for her. And I love everybody's responses because I think they speak to either your own lived experience or knowing this work. Because I think that if you aren't familiar, you might say, well, why would it be challenging if mom couldn't breastfeed? Whereas if that's a lived experience for you or friends or people you work with, you know that that can be a traumatic experience. So I appreciate everybody's responses. So I gave Mia the checklist and she got a 22, which indicates significant impact, clear signs of trauma, as we honestly suspected, and that intervention is strongly recommended. So let's go through her responses to think about the nuance of the questions and how they help us understand her. So I am going to go through just a handful of select questions. And if people have specific questions they'd like to know more about, please let me know and we'll go into those questions as well. Um, so, question one, do you have negative beliefs about yourself, such as I'm not good enough, I cannot trust anyone, I'm not safe, that started in childhood and feel similar to how you felt during your birth experience? And Mia says never. So I want to start with a never question to show that each question, even if the answer is no or never, still gives us information, data, and insight. Because with Mia, I would be very surprised that that never is her response. As people mentioned in the chat, she's tearful. She has these historical challenges, the history of childhood sexual trauma, things like that would make me think you probably do have some negative beliefs about yourself. And so I definitely would not clarify with her and say, what are you talking about? That doesn't make any sense. But I would be curious to know why she feels that way. And I would really start to think about there's probably a high need for compartmentalization. She's successful in her career, she has a family. There's probably a lot going on that she does to protect herself from this trauma. And that feels like it's evident in that question. That question, if she had answered sometimes or always, I would be thinking about from a CBT perspective, cognitive restructuring, because we know that birth trauma can deeply affect a mother's self perception, leading to shame, self blame, feelings of inadequacy. And through a trauma informed lens, we can use cognitive restructuring to help her sort of recognize these distorted thoughts. We want her to start reframing them, having self compassion, and replacing the thoughts with more balanced and affirming beliefs. She can do that through acknowledging her strength, her resilience, and really understanding the complexity of the self blame. Specific tools you can use would be mindfulness, journaling, guided self reflection. Also, there are ways, and probably from more of like a dynamic perspective, that just by being with her and talking to her, you can help listen to the way she talks about herself. So, for example, Mia might say something like, I know I'm so stupid to ask this question, but. And when you hear someone talk about themselves in that way as a therapist or a psychologist, you don't want to just ignore it. You want to either indirectly address it and say, that's a great question, here's the answer. Or you might say, I'll definitely answer your question. I heard you call yourself stupid, and I just wanted to take a second to understand what that voice was about or what you were talking about. To really sort of say to them, I'm actually not okay with you talking to yourself that way, and we're going to think together about how that can be changed. And by talking about yourself differently, you often think about yourself in a different way. So, question two. Before motherhood, did you experience physical symptoms, tension, pain, or unexplained illnesses from trauma, recognized or unrecognized at the time, that resurfaced during pregnancy, birth, or postpartum? And Mia answers always. So in here, we're thinking about body awareness. It's really, this question is helpful in understanding that physical psychological connection. And so for us, or at least for me, when I'm reading this, I would think, oh, okay, this is definitely about her miscarriage and her C-section, but you never want to assume. If you feel like you're in a place to support her, and I say that because sometimes we're not in our own place to support, and that's okay too, but we have to be mindful of knowing, okay, then I need to refer out or get her another resource instead of keeping on asking and sort of forcing yourself to support and maybe not being fully present. So if I'm able to ask, I would say, you answered always. Could you tell me a little bit more about what you're referring to? And Mia, for example, she actually talks about low back pain throughout her pregnancy and extreme pelvic girdle pain. So that's pain in the pelvic area, hips, and sort of lower back during her third trimester. And she said she remained mostly sedentary actually during her third trimester due to that. So it pretty greatly impacted her. Um, and it's interesting, as a psychologist, I would start to think, so the physical pain you're describing, if we think about it from a dynamic sense, is in the pelvic region. You have a history of childhood sexual abuse. My thoughts are there is some connection there that the body is expressing the psychological pain she may not be able to express verbally. It's expressing it somatically through the body. Also, if we think about low back pain, our minds might go to like just carrying the weight of the world, the heaviness, sort of thinking about how that pain, sure, a belly's heavy, a baby is heavy. It's likely physical and psychological. Another thing that can be helpful in sort of understanding whether it's purely physical, purely psychological, or sort of where that combination is, can be asking if they've received physical support and how that went. So they might, Mia might say, oh, yeah, I went to pelvic PT. They were great, but I actually was still sedentary the rest of my pregnancy because it was too severe. And you think, so purely physical interventions didn't work. Likely to me, that speaks to it also being psychological. And so she's going to need a combination of physical and psychological help. In general, when we're thinking about body awareness, this refers to the body's ability to tune into itself, to hear its signals. With traumatized mamas, birth trauma mamas, we're some are very connected to their body, so they'll tell you exactly what they're feeling and know it down to the inch, and others will say they are totally disconnected and you can sometimes tell or feel. So they might have muscle tension, shallow breathing, dissociation, which I'll talk about in a second, racing heart, because they just have no idea that when something psychological happens, their body is playing it out. And our role there is to help them build that body awareness and try and understand how they can integrate those physical cues and the psychological symptoms, which can lead to self regulation and healing. And so basically, what we're trying to get is that mind and body to connect. Um, I know I've mentioned dissociation a couple of times. Since many of you are therapists, you're probably more comfortable than the average person with it, but I want to talk about it because a lot of people hear the word dissociation and are immediately afraid and turned off. And I really want to talk about how normal it is in trauma. And really, it's so helpful to see someone during these experiences to help them see themselves. Because when I'm talking about dissociation, ways you can see it in your practice might be someone's telling you about something really horrific, and they just sort of have this nonchalant, dazed look, and likely they are dissociating from what they're actually saying. You yourself might dissociate and not even realize it, meaning maybe you have sort of like a common route you drive to work or to drop the kids off at school. You get in the car and then you're there. And you sort of missed the moments driving there. Likely you were just dissociating. So I think if you can see it as a not scary thing, as many of you might already, but for the people who aren't as familiar with trauma work, you can start to see dissociation as something that makes sense to disconnect from the body when something really horrific is happening. It means you can treat it. You can sort of help someone integrate mind and body. And you'll, with birth trauma mamas, you'll hear it a lot in terms of what was done to them. Sometimes they'll say, like, during my C-section, I was looking down on myself. I wasn't actually in my body. And so that means that that was a way for them to protect themselves. They couldn't sort of be present. They couldn't feel those experiences. And ways to help people with dissociation, breathing techniques, grounding techniques, mindfulness, also just helping them connect. If you start to see a dissociation or a disconnection, to say, I feel like you're not here right now. As a therapist, sometimes you actually might notice it within yourself and be able to point it out. So, since I know the audience is mainly therapists, people are probably comfortable with me talking about this, but I don't know if you've ever been in a session and all of a sudden you're like, On my grocery list, yeah, I don't have chicken. Okay, I should really add that chicken. And someone's still talking. Then you're like, oh my gosh, I can't believe I wasn't paying attention. What you might actually want to be thinking about is, are they dissociated from the material or from themselves? And so you're disconnecting. And so you might want to say to them, I actually, I'm curious about what just happened there. I felt a disconnection. Did you feel it? They might say no, I don't know what you're talking about. Or they might say yes. And sort of that gives you that opening to talk about it. So being aware of yourself in the room is really important, and also being aware of the cues and signals you're seeing from your clients. Additionally, um, oh shoot, I think I missed that. Okay, I didn't miss it. So additionally, in looking at question 2, and this is what's helpful about the Well Mother checklist, is we don't want to just look at the questions, or we can, but it can also be helpful to look at the whole diagnostic assessment, because question 2, which talks about body, is similar to question 7, and I'll go to that next slide, which is also talking about physical pain. And what we want to do here is compare question 2 and 7 to get a holistic picture of the client. So in question 7, have you noticed recurring physical sensations, tightness, numbness, or heart racing related to your birthing experience? And Mia also answers always. So this actually gives us even more data than the last question, because it tells us that she has a tendency to express her psychological pain physically. And that's really something then we should be thinking more about. We might, during session, when we ask a question and she doesn't have feelings about it, say, can you check in with your body? Is there anywhere that you're feeling that, feeling discomfort? It's a tool to both get the client to connect to themselves, and it's a tool for you to get more information to be able to work with. Okay, I do want to pause. Are there any questions on just those first few, or do people want me to keep going?
There was a question asking if there's a PDF.
I don't have a PDF right now, but if you email me, I can let you know once I have the PDF available. Right now, I just have it online. Well, if questions come up on the checklist, please let me know. So I'm going to keep going on question 3. So, have previous conceptions, birth experiences, or pregnancy losses left you feeling emotionally impacted? And Mia answers sometimes. Um, and what we're thinking about with question 3 are safe spaces. Because with this question, we're talking about a lot. We're talking about conception. So maybe we're talking about assisted conception. We're talking about birth itself, which could mean induction, it could mean medical interventions. And we're talking about pregnancy losses and the emotional impact. We're also, I didn't include breastfeeding in here, but Mia may go to think about breastfeeding as well in this. Because for her, I am thinking about, and I asked her, and she said she is thinking about her emergency C-section, her breastfeeding journey, her prior miscarriage, and that is sort of what is coming up, and she feels emotionally impacted by. I want to give some themes that you should be listening for when you're hearing someone talk about miscarriages, C-sections, and breastfeeding journey. There are a lot of overlaps, and that is in part because there are ways in which all of these connect and that trauma is connected. But my hope is that that can help people understand, oh, someone's talking a lot about shame. They had a miscarriage. Maybe this is the trauma of that. What do I do? So with miscarriages, I'll start with that. Sort of feelings that you might notice coming up in your clients are them not feeling like they're not good enough, not able to keep baby safe, their body's failing, being out of control. There's loss, there's grief, there's past loss and grief that may come in. There's also a loss of a future, a feeling of life. I expected it to look this way. I expected certain months to have baby. I expected certain milestones to hit. And just sort of that idea is all gone. With C-sections, a lot of times what you're hearing and what you're seeing is, and again, none of these are exhaustive lists, but what you're seeing is a not good enough mother. You're seeing someone who says their body is failing, they're feeling out of control. A lot of mothers talk about feeling very trapped during the procedure, losing their autonomy, losing their authority, feeling as though birth was done to them instead of an experience they had. There's mom guilt. Someone wrote in the chat that societal expectation of self. I thought I would give birth vaginally. Um, Loss, grief, anger, shame. Past medical traumas may really come up for someone who's experiencing an emergency C-section or C-section, things like that. And then breastfeeding also can bring up similar feelings. So, this feeling that I'm unable to provide for baby, I'm able to nourish baby, I can't meet their needs. You'll hear a lot of moms who are really struggling with the fact that they can't breastfeed or having trouble breastfeeding. They'll say, like, I'm making the bottle and I'm just so angry and I'm crying. And there are all these feelings that I just want to be able to give to baby in the way I expected of myself, which can lead to loss, shame, grief, anger, feeling out of control. So, again, there's a lot of sort of similar themes you're seeing, but it's really important when you're seeing and hearing those themes to be thinking about these traumatic experiences during birth or surrounding birth. And the way we would treat that is to create a safe space. So we want to create emotional safety and psychological safety so that the client can really express all of their fears, all of their grief, all of their distress, and not be worried that you are going to shame them, that you're going to compare your own experience. I mean, you could probably do a whole workshop itself on self-disclosure, but it's important to be able to relate to a client, but it's also important to be able to know when you're sort of like trauma dumping or competing with them to connect to them rather than just connecting through your knowledge and the way you're there for them. So sometimes you may disclose, I know what that feels like. I've been through that same thing, but you might not say, oh, you thought your emergency C-section was bad. Let me tell you about mine. Most of you know that, but it's important to think about because trauma, if it's something you've also experienced, it can trigger your own trauma. And sometimes you really have to be mindful of the way you're reacting in the room. But your goal is to really create safety. So, again, being respectful, supportive, using extremely supportive and compassionate listening is imperative, giving them authority, choice, and really sort of making sure they know that they are in charge of their body and their decisions in a way that maybe that was taken away in the past during their traumatic experiences. Um, One thing I like to talk about, usually when there's different modalities and birth workers in here, it's different. But I like to think about informed consent because it can be a great way for us to tell mothers that they are safe in this space here. And so, especially if you're using a physical modality, I know there's only one or two people, but you might say to someone your usual informed consent agreement and talk through it, or you might just have a sort of, are you comfortable with this, or I'm going to begin this work. And with someone with a trauma history, you might take an extra step. So let's say they say, yes, of course, I'm fine if you begin this work or put your hands on my hips, whatever you're sort of asking for the consent from. And you might say, I know your mind is saying yes. I'd actually like you to take a second to check in with your body and tell me if your body also agrees and says yes. And then actually give them that minute, sort of take a step back, look down, give them a second to really check in with themselves. And they might say, actually, my body's saying no, if I'm being really honest with you. And sort of depending on what's going on or the way you work, you might say, okay, that is the decision we make then. We do not do that. I do not put my hands on your hips. Or you might say something like, what would make you feel safe right now so that we could keep going? Because it seems, at least from my experience, there's this sort of belief that we can't ask. And that's the opposite of what we should be doing. Someone may not know the answer, and then you may have to process those feelings. But if we ask, what will make you feel safe, or what are your thoughts on that? We're really giving them back that control and back that choice. So, again, it's really important to think about helping in just little ways of connecting mind and body, creating a safe space of I am listening to all of you and you run this show. Sort of, I will sit back and be respectful and during it. Okay. With time, I'm going to go to two more questions so I can maybe wrap up in the hour or and hopefully leave a little bit of time for questions. So, question 5 is before this birth experience, did you feel emotionally unsupported by family, friends, or healthcare providers? So, this question is talking about relational repair, and Mia answers never. So that means she felt supported. That's great. It's so great to know that she has had a safe space. If someone says they have not in the past felt supported, that means the work is a little different or a little harder because we not only want to get them back to that safe space, we actually also need to create it. But we do that through relational repair. And I want to, again, as I did with question 2, sort of show the value of using the whole checklist, like looking at it holistically, excuse me, and compare question 5 to question 15, which says, has your birth experience made it harder for you to trust healthcare providers or seek medical care? So before we're talking about the past, now we're talking about the future. And with Mia, she says always. So to us, that indicates previously she felt safe, she felt good. In the future, something has shifted and she does not feel safe anymore. And so that's important for us to integrate and to think about, okay, a trauma occurred that has actually changed the way she views her relationships. And so it is our work to create that relational repair. And we do that by first understanding where it's ruptured and then working on the repair. So, oftentimes in birth trauma, you're seeing mothers who have really lost trust in themselves and others. And they've lost trust in their instincts. They've lost trust in the world, their relationships, this idea that people are safe. And oftentimes, because birth can be in a medical setting, they've lost trust with medical professionals, medical interventions, and maybe even their own pregnancies. And so it's important to really think about some of those areas as needing relational repair, rebuilding that trust internally with the self and externally between providers. Ways I think about doing that is processing that trauma, processing that medical trauma. I 99% of the time recommend mothers who've experienced birth trauma and are going on to have another baby switch providers because unless we're in a rural area or there's actually no one else they can go see, a lot of the trigger is going to be in seeing that individual and being in that same hospital. And so just by changing the environment, we're giving the body a chance to respond differently. I also want to help strengthen bonds with family, with friends, through support groups, and also get the mother to reconnect with their own bodies and their own intuition. So, trusting their emotional cues, trusting their physical cues, and ways you can do that validate their experiences, create a safe relationship in the work, and create trust. Sort of there are big ways we can do that and there are small ways we can do that. I think we sometimes forget about the small ways. If I say to someone, I'll see you at our appointment tomorrow at 2 and I show up at 2:05, I have broken trust and it feels like nothing, but to that person it might mean a lot. Or maybe it doesn't mean anything, but we always want to really point things out. So we want to say, I know I said I would be here at 2. It's 2:05. I'm sorry for the delay. Next time I will be on time. And if next time you're not on time, you apologize again and maybe you say, I don't think I'm able to be on time. Can we talk about how that feels? So it's really being realistic with what you can do. And that allows the person to understand that their feelings are valid, their reality is valid, which oftentimes in birth traumas, women will second guess their reality, especially when they're getting a lot of, um, you know, babies healthy after they've experienced a birth trauma. And the feeling is not at all that they're not so glad. if baby is healthy. But the feeling is, but I wasn't healthy. I was harmed during this experience. And both can be true. Baby can be healthy, and my birth trauma, my birth experience was traumatic. So again, really knowing how to create trust in small ways can make huge, huge changes. Um, I'm just gonna, so that's the gist of the checklist. I have found it transformative in my practice. And my hope is that if you are interested in it or want to use it, it can really transform your practice because again, it's a non-diagnostic assessment, but it helps the 1 in 3 moms, I just can't say that enough, who have experienced birth trauma. It's also a conversation starter. So let's say you're not really sure how to break into this conversation, or mom is sort of like, I don't know what you're talking about. We usually talk about my relationship. What's going on here? It's like, okay, well, let's give this a try. Um, Also, sometimes if you're not in the mental health profession, or if you want to refer out to a trauma informed provider or a trauma, someone who specializes in trauma, sometimes you can also use the checklist as like the blame of like, oh, well, it says here that you should do this instead of I'm saying. And that can sometimes feel safer for someone with trauma because they can sort of feel like, okay, there's this external thing we can both talk about. I'm not actually talking about our relationship. I wouldn't hurt you if I didn't do it. I'd hurt the checklist. And so it can be a safer way to talk about trauma. I like that you can use it the way you want to use it in terms of it being customizable and empowering. My hope is that it encourages moms to reclaim their narrative because I didn't go through it, but I feel like I just have to. Question 9. Question 9 in the checklist is my favorite question. And I think if you don't use anything but this question, or if you don't walk away with anything from this presentation but this question, I have done my job today because basically this question is saying, when you think about your birth experience, how often does it feel traumatic to you? Which is the most important thing we can say is you as a mama, you define if it's traumatic, you define how it feels, and we do all of our work based on your experience. You have choice, you have autonomy, you have control. And again, back to that idea of like just asking. Because sometimes I hear a birth story and I'm like, wow, that must in my head thinking that must be so traumatic. I don't know how they're getting about their day. And they're like, no, that was fine. I felt very empowered. The way I was spoken to was very caring. And so it wasn't good. I wouldn't do it again, but I wasn't traumatized. Okay. And other times I hear a birth story and I'm like, okay, sounds pretty run of the mill. And they're like, oh my gosh, I am so traumatized during this part and that part. And so it's really important to give autonomy, give control to the survivor or the mama. Whoops. Okay. So, quick review to heal trauma, body stores trauma. We're working towards attachment and safety, integration over avoidance. You'll hear many people say that was in the past. Why do I need to talk about it? Because it's still in the present, it's still in the future. And having self compassion, addressing shame, guilt, and rebuilding self and identity. Um, and what I really want to say is I am so grateful for everyone being here because Sally and I were talking before everyone logged on that just birth matters. And we need to change birth for all mothers. And the fact that you guys are here trying to change birth for mothers is so meaningful to me. And so, my hope is that we do change birth, that we find supportive and safe networks. We work from a trauma informed care perspective. Hopefully, the Well Mother checklist can be a tool in your toolbox, and that we refer to each other to providers who are, comfortable, well ingrained in the birth trauma world so that we can really, again, change birth. Yeah, that is it for me. I know I only left a few minutes for questions.
That's okay. I'm going to end the recording